Good morning. I'm Dr. Shaun Hussain. I'm the director of the UCLA Infantile Spasms program. And today we're going to go through a whirlwind tour of infantile spasms. So if you have any questions along the way, feel free to reach us on Twitter at #UCLAMDChat. And we have pretty meager goals for this morning. We just want to talk about identification of infantile spasms, the diagnosis, treatment, and some research endeavors that are coming our way. And now we're going to switch to some video. So this young boy, this is a video borrowed from YouTube with permission, and you just saw the first seizure in a cluster of spasms. As we watch this, every few seconds you'll see this young guy have a little shrug of his shoulders, a little extension of his arms. You can see he looks a little bit upset or alarmed. This is very typical of infantile spasms. And these are very different than what you think of when you hear the word seizure. This is not an adult who has lost consciousness or fallen to the ground. There's no violent convulsion. There's no loss of urine or stool. A lot of people would look at these events and say, what's the big deal? But we're going to talk about what the big deal is and about the specific consequences of infantile spasms when they go unnoticed or undiagnosed and insufficiently treated. Okay, so we can switch back to our presentation now. And we'll begin with some vocabulary. So this gets confusing when you try to look this up on the internet, but infantile spasms are the same as epileptic spasms. And West syndrome specifically refers to a triad of infantile spasms. These are the seizures, hypsarrhythmia, which is a pattern on electroencephalography, as well as mental retardation. But the goal of infantile spasms care is really to prevent West syndrome. We want to identify and successfully treat infantile spasms before any cognitive impairment happens. This is just a screenshot of hypsarrhythmia, and you can see this is absolutely chaotic. This is not what normal brain waves look like. This just looks like static noise. And it's this static and this chaos that prevents kids with infantile spasms from learning and developing. But a lot of times, if you're a parent and you're dealing with a practitioner who says that your child does or does not have hypsarrhythmia, it can get confusing because that answer can change. And that's because there's a spectrum of hypsarrhythmia. As we look at these panels, as we move forward from A to D, you can see that the brain waves get progressively more chaotic and harder to discern. And it's this spectrum that is very typical of hypsarrhythmia. What is still unknown is how much hypsarrhythmia needs to be removed or cured to secure good developmental outcomes. So how common is infantile spasms? The peak age of onset is between 4 and 12 months of age, and it will usually go away by itself by the age of 24 months. But the goal of our therapy and early diagnosis is to treat it quickly and abolish it well before that age. If infantile spasms are left to their own devices, the cognitive and epilepsy consequences are staggering. So the goal is to treat infantile spasms quickly or potentially even prevent it from ever happening. Infantile spasms affect 1 in 2,000 births here in the United States, and there are about 2,000 new cases each year in the United States, which makes this a fairly uncommon disorder. You might think, well, how many general pediatricians are there in the United States? It turns out there are 30,000 of them, and based on the frequency of infantile spasms, each pediatrician will see 1 new case of infantile spasms about every 15 years. So that's about 2 per career. And that's good that infantile spasms is not more common because it is a scary diagnosis in a severe form of epilepsy, but it's bad because your typical pediatrician will not be adequately familiar with this condition, might not recognize it. They might not think infantile spasms from a parent's description, and that delays diagnosis, that delays treatment, and that's bad for outcomes. So let's talk about the worst case scenario. This is every parent's worst nightmare. Untreated or insufficiently treated infantile spasms almost invariably result in severe cognitive handicaps, including mental retardation. Kids, although they might stop having infantile spasms before the age of 2, they are likely to have other types of epilepsy if infantile spasms are not adequately treated. There's even risk of death with epilepsy, and that extends to infantile spasms. And the secondary costs are staggering. This includes things like lost work productivity for parents, less attention for siblings. Sometimes the secondary costs are worse than the epilepsy itself. The best case scenario is that kids can be normal. So in spite of this terribly scary lecture and this alarming fear of terrible epilepsy and cognitive harm, some kids can be normal with a couple caveats. Number one, you need to identify infantile spasms quickly, ideally less than a couple weeks. You need to treat aggressively and successfully. And the hope is that whatever is causing infantile spasms is something mild, that the cause itself is not a source of cognitive harm or future epilepsy. So in short, to secure the diagnosis, we need to do something called video EEG, or video electroencephalography. And this is basically two tests in one. It's a video running that watches the patient while about 20 electrodes are attached with a temporary glue to the scalp to monitor brainwaves. And we're specifically looking for the seizures, which are the spasms, and variants of hypsarrhythmia, which is that static noise that we saw on prior slides. And physicians will often use the term differential diagnosis, and this refers to figuring out that behaviors or something that the parents are worried about aren't actually seizures or infantile spasms. And the top three things that we identify are reflux, kind of heartburn that adults have. Infants can have too, and when they get heartburn, they often have movements that resemble infantile spasms. There are also a lot of normal movements that happen in sleep, and as many of us know, babies do lots of weird movements that are within the spectrum of normal, and we call those behavioral. This is what I like to think of as the Zagat guide to drug therapies for infantile spasms. We're going to march through each of these. First, we'll focus on vigabatrin, whose brand name is Sabril. This is an artist's rendering of the feared side effect of vigabatrin. And what you can see in the right frame, there is darkening of the peripheral visual field. And what we've seen is that about a third of older children and adults who take vigabatrin in high doses for several years will get irreversible peripheral field vision loss that does not go away. It does not go away when you stop the drug. So once this happens, it can't be reversed. But what we've seen in our experience at UCLA in evaluating the last 150 patients who received vigabatrin, we could not identify a single infant who received vigabatrin for treatment of infantile spasms for whom we thought identified vision loss could be linked to vigabatrin. So why is there this disconnect? Why are infants at lower risk of these vision side effects? We don't know, but it's good for the infants at least. Next on the list, we've paired ACTH, adrenocorticotropic hormone, and prednisolone. So these are two hormones, and as we can see in this slide, ACTH is made in the brain of mammals, including humans, and it is a hormone that travels in the bloodstream to the kidneys, and the kidneys make a hormone called cortisol. And cortisol is a nearly identical molecule in comparison to prednisolone. So these two drugs are very much linked in this natural pathway of production in the body. But we have also found that they are fantastically effective when given in alarmingly high doses. These drugs are not benign. They have lots and lots of side effects. This is kind of a list from Google, but the ones we really worry about with short courses of therapy, which are typically 2 to 4 weeks, are suppression of the immune system. So we worry about little infections like an ear infection becoming a big or potentially lethal infection, like sepsis, which is an infection of the blood, meningitis, which is an infection of the brain, or pneumonia. To give you some sense of that risk, in the experience at UCLA, after treating approximately 600 patients with these therapies, there have been 2 deaths and about 10 near misses. We also worry about high blood pressure and high blood sugar occurring with this treatment. And these are very much treatable. So even if these side effects were to occur, we would simply use a medication to bring down blood pressure or bring down blood sugar and continue with the course of therapy because the consequences of infantile spasms are so much greater than the consequences of these side effects. This is a little schematic comparing ACTH and prednisolone. You can see they have some important differences. ACTH is the most popular first-line therapy for infantile spasms in the United States, but internationally, prednisolone and vigabatrin dominate the field. There have not been adequate studies comparing the best doses of ACTH and prednisolone, and there have not been adequate studies comparing the best doses of these hormonal therapies with vigabatrin. But as you can see, ACTH is an injectable medication, so parents are trained to give injections of this gel to their children twice a day for 2 to 4 weeks. And prednisolone, by contrast, is a syrup. Now, it's not a shot, but it tastes terrible. I can attest to that from personal experience. There is a huge cost difference here, and I think this has been a source of a lot of political alarm. But the thing to remember is you shouldn't be worried about the cost, at least in the United States. There is access to these drugs for everyone with infantile spasms. In those rare cases where we've heard reports of lack of access, it has usually been because there's not been sufficient advocacy on the part of a patient's practitioners, their neurologists or pediatricians. We worry about the delay that accompanies the use of ACTH because ACTH is not at your neighborhood pharmacy. We have to order it. There are special approvals. There's a fairly complicated but quick insurance authorization process that's involved, and that often delays therapy for a couple days. And when it comes to infantile spasms, every hour is important, every day is important, and we don't want to delay therapy. And this leads a lot of people to try prednisolone first. Above and beyond the cost, any delay in therapy is more critical. This is a summary of studies that have been conducted comparing ACTH and prednisolone. And the take-home message is that the top 3 above that middle gray line, were older studies suggesting that ACTH was more effective. Those below the line are contemporary studies suggesting that prednisolone in high doses may be equal, or in one case, the very last example, it was superior. But the ideal study comparing what we think is the best dose of prednisolone and the best dose of ACTH has not been done. So there remains some debate as to which of these therapies is best. Given this uncertainty, the UCLA therapy protocol is as follows, that we verify a diagnosis of infantile spasms and immediately start prednisolone because it is immediately accessible and because it's not a shot. We give it 2 weeks to work. If it has not worked within 2 weeks, we immediately switch to ACTH, give that an additional 2 weeks. And if that is not successful, then we try other things. So the take-home message here is not necessarily the sequence, but that we act quickly, that we don't delay therapy, and that if any given therapy that you choose isn't working, you need to switch teams after a couple weeks because time is of the essence. Now, further down on our Zaga guide is zonisamide, which is also called Zonegran, and topiramate, also called Topamax. And both of these therapies are relatively inexpensive. These are common anti-seizure drugs that have a broad spectrum of action, and we think that they might be effective in treating infantile spasms, but we only think they're a little bit effective. We worry about zonisamide in particular because of the risk of kidney stones, and topiramate, because of a similarity in the molecule, also carries that same side effect, and both of these drugs can cause reductions in appetite. And here we see an example of a pediatrician's growth chart in which we can see the patient's weight at the bottom of that chart, what we call falling off the growth curve because their appetite has been so suppressed and that they're not growing well. So we always keep an eye out for growth when we're treating patients with these therapies. There are a few special circumstances in which a specific cause of infantile spasms tells you to use a specific therapy. And the big ones on that list are tuberous sclerosis, which is a neurocutaneous disorder, meaning that it has manifestations in the brain, in the skin, and kids with tuberous sclerosis seem to respond exceptionally well to vigabatrin. So in that population, vigabatrin should be the first choice, not steroids or ACTH. In a disorder called paradoxical responsive seizures, it is maybe obvious that you should use pyridoxine to treat their seizures because it is fairly safe. But this is only a rare cause of infantile spasms and should not be used first line without other therapies combined. The last one, GLUT1 transporter dysfunction, refers to a problem in the brain in which we can't shuttle glucose to the brain appropriately. And the ketogenic diet is a perfect treatment for this disorder because it shifts the brain's reliance on sugars and carbohydrates to fats, which are very prevalent in the ketogenic diet. And in the last 15 years, there have been 15 studies extolling the virtue of the ketogenic diet and that it is highly effective for infantile spasms. Let's just talk about the diet a little bit. In the normal diet, about 25% of calories come from fat, but in the ketogenic diet, it's about the opposite. Only about 15% of calories come from sugars and proteins, and the remaining 85% of calories are derived from fat. This is a pretty extreme diet. This is not something you could do by yourself. we typically admit these patients to the hospital to ensure that this diet is safe. The only catch is that it is not always as effective as advertised. In looking at the UCLA experience, we have been, unfortunately, very unsuccessful using a ketogenic diet to treat infantile spasms. And I suspect a lot of this discrepancy is because the quality of the prior 15 studies was not great. Actually, our study too was not perfect. And there have been no perfectly rigorous studies evaluating the ketogenic diet. And I suspect that the truth is somewhere in between, that it works for some kids, but not all. And my chief worry is that even if it is effective, it's not effective fast enough for most kids. So there remains some confusion as to when we should use the ketogenic diet. Where in the sequence of rapid aggressive therapy does this treatment belong? So that's a job for future research. The remaining drugs that we have out there are not great. I would only give them half a thumbs up for those on the left. Those have some evidence that they are effective in treating infantile spasms, but on the whole, they are not game changers. And the drugs on the right either are known to be ineffective or may present some risk that they might cause infantile spasms to be worse, or they might actually cause the development of infantile spasms in children who are at risk. Lastly, we're going to talk about surgery. These are cross-sections of a boy with infantile spasms, and you can see where the red arrow is pointing. There's a big chunk of abnormal brain on what is his right side, so it's reversed on this image. And this is a what we call FDG PET MRI co-registration. It's a mouthful, but this is a digital combination of structural MRI and a test called PET, which looks at metabolic activity in the brain. And we can see that that same region is very abnormal. So what did we do? We took this kid to the operating room, and what you see here is the brain exposed, and there are grids and strips of electrodes, and these examine electrical qualities of the brain, and it's kind of the last stop before you do a surgery to decide what you take out. In this case, we took out the entire right half of this boy's brain and cured his infantile spasms. Now that will shock a lot of people, that we've taken out a huge piece of brain, but you'd be amazed what you can get away with in a very young patient. So this patient, if you meet him today, he's about 9 years old, you probably can't even notice that there's anything wrong. He has a very slight limp, and he has less than great dexterity in his left hand. But aside from that, he's pretty normal. He's in normal school. He plays games and is learning like other kids. And this was an example where a dramatic and aggressive approach made all the difference, because had he not had this surgery, he would have been devastated. This is a CT scan of his brain after that surgery. So you can see a big chunk was taken out. Now this is where all the excitement is these days. We've seen this on the internet, on CNN, like you can see Sanjay Gupta pictured here. And he really came on the scene in 2013 with a trio of documentaries looking at the potential for marijuana as a treatment for many disorders, but specifically for pediatric epilepsy. And he specifically profiled this band of photogenic brothers who are based in Colorado and are the face of the realm of caring. And this is a group, a dispensary producers who make a form of medical marijuana that is rich in the compound on the right, this thing called cannabidiol, or CBD. We think that this might have potential as an anti-seizure medication and might have potential to treat infantile spasms. But the thing to remember that this is a very different chemical than tetrahydrocannabinol, the chemical structure on the left. And this is the one that we usually link to the effects that most people think about when they think about marijuana: the high, hunger, amotivational syndrome, paranoia, unmasking of psychosis. So cannabidiol may be a safe therapy. It may have very few side effects, and it might be fantastically effective in the treatment of infantile spasms. And this has given us a lot of hope and inspiration. We have an ongoing trial here at UCLA examining the potential effectiveness and safety of cannabidiol, and we're hoping it pans out. But just like any rigorous study, it might show that cannabidiol doesn't work, and we might be sent back to the drawing board looking for new therapies. So I want to close by talking about risks. I think for any parent or pediatrician or physician who is taking care of their child or a patient with infantile spasms, there are a lot of risks that get very scary when you talk about infantile spasms. We talk about immunosuppression or heart failure associated with prednisolone or ACTH. We talk about bleeding with surgery, or vision loss with GABA Train, or kidney stones associated with zonisamide, or anesthesia and radiation associated with tests for infantile spasms. But we need to remember that the single greatest risk is that any treatment we're trying might not work, because the consequences of unsuccessfully treated infantile spasms far outweigh the consequences of any particular drug. Okay, I think we'll take a break here, and if there are any questions, we'll entertain them from Twitter and beyond. And I just want to quickly acknowledge trainees in our laboratory who have been instrumental in conducting this research, my collaborators here at UCLA and beyond, and certainly the foundations and pharmaceutical partners who make our research possible. Okay. Okay, our first question is, how does Sabril treat infantile spasms? So Sabril is the brand name of vigabatrin, and we believe that its main mechanism of action, the way it works, is that it inhibits an enzyme that breaks down GABA. And GABA is the key inhibitory neurotransmitter or messenger in the brain. So the idea is that you stop it from getting broken down, so that means that there's more GABA hanging around in the brain, and that is inhibitory, that it's inhibiting seizures. But we don't actually know the whole story. We know that other drugs that work on the same system don't work for infantile spasms, and some of them may make infantile spasms worse. So the hope is that we need to figure this out a little bit better. There are a few similar drugs along the drug development pathway that are coming to the forefront that might be even better than vigabatrin. And the hope is that they are equally effective, but don't carry risk of vision loss and other side effects. Second question, is medical marijuana safe for young children? How can my child participate in the UCLA trial? So the answer is simply we don't know. Now, we know that marijuana in general is not a great compound to be abusing. We know that it's associated with learning problems in teenagers and adults who abuse it frequently. But these risks have to be balanced against the risks of epilepsy and specifically against the risks of infantile spasms. We've talked about how inadequately treated infantile spasms can be devastating. So certainly if you're the parent of a child and you have failed first-line therapies like prednisolone, ACTH, and vigabatrin, you're not left with very good options. And there are certainly situations in which the risks of medical marijuana are far outweighed by the risks of infantile spasms. But to take a step back, you have to think about medical marijuana, where you live, what state, what country. The laws surrounding the use of medical marijuana, even for children, vary quite a bit. Throughout the United States, even though most states have state provisions for medical marijuana use, it is still federally illegal. So anyone who is prescribing or recommending or using these therapies is potentially subject to prosecution or arrest. And the current administration has issued a directive to not prosecute parents who are using this for their children. But that might change. We don't know what will happen with potential changes in the political tides. But having said all of that, do what's right for your kid. And even just taking a step back, if there's anything I can tell you, it's that you need to advocate for your child or your patient. You need to be quick with diagnosis. You need to be quick and aggressive with therapy, because hesitation can be a catastrophe. Our last question, what is the intellectual prognosis for children with infantile spasms? It is all over the place. It very much depends on how successful you are in identifying, how quickly you are in successfully treating infantile spasms. A minority of kids with infantile spasms who have an unknown cause of spasm or something that's mild can have normal intellectual outcomes. But still, with best technology and the best drugs available to us, the majority of kids do not have normal outcomes. And mental retardation, intellectual impairment are a possibility. And that's why we are pushing, why we're aggressive, and why we're taking risks in the diagnosis and treatment of infantile spasms. Okay, with that, I believe we're done. Thank you all for your participation, and this will be on the web pretty soon. Thank you.